Good evening, everyone. So this week we'll be discussing pathophysiology of alopecia areata. Now, the reason that we are discussing pathophysiology of alopecia areata is that for the past few weeks we have been discussing hair anatomy, hair physiology, the hair cycle. So I thought it becomes important to discuss the pathophysiology of one of the most common hair loss disorders that we see in our OPDs. And we will discuss the pathophysiology of alopecia areata because we have a background of the hair anatomy and the hair cycle. So we'll be easily able to grasp what all is happening when a person starts to lose hair from a certain area of their scalp. Okay, so with the background of alopecia areata, if I ask any resident what exactly do they mean by the pathology of alopecia areata, the answer that usually comes is that it is autoimmune damage to hair follicles. It is a very, I would say, a misinformed kind of answer. I hope that after this video lecture, you'll be able to frame the answers a bit better and you will have gained the insight to understand what exactly is happening in alopecia areata, okay? And why it is not just an autoimmune disorder. Why autoimmunity is not the only factor for the onset of alopecia areata. With that in mind, let's start our discussion this week on pathophysiology of alopecia areata. Alopecia areata is a common chronic autoimmune inflammatory disease. Remember, I've not used the term autoimmune disease. I've written autoimmune inflammatory disease that causes non-scarring hair loss. Remember non-scarring. So in alopecia, you have non-scarring. If you see atrophy in a patch of alopecia and you're very sure that it is alopecia areata, the atrophy could be because of inadvertent use of topical corticosteroids or intralesional corticosteroids for that matter. Now, alopecia areata may spontaneously resolve or progress to permanent hair follicle loss. Remember, in long-standing alopecia areata, you can have permanence in terms of hair loss. Okay, so whenever see, this is entirely a personal opinion. Books mention this to spontaneously resolve in about 6 months. I do not believe that if there is an onset of alopecia areata less than 6 months, that you should not treat. The reason for that is it causes a lot of psychosocial distress to the patient for having a bald patch over the head. Another thing is that let's say after 6 months, if the disease does not resolve spontaneously, you have actually allowed the disease to progress to permanent hair follicle loss. That's the second reason. Third reason is that what happens if the disease is progressive and the patient comes after 6 months to you and says that I waited for 6 months, it has not resolved. And now instead of dealing with one patch, you're dealing with five patches. So it's better to treat even if it's a single patch, get a history of progression, take a photograph to document progression, but do treat. Okay. Now, alopecia areata is a T cell mediated autoinflammatory damage in genetically predisposed individuals. Not everyone will get alopecia. Only genetically predisposed individuals who have a tendency to develop alopecias will develop alopecia areata in their life. Now, this kind of genetic predisposition that we have in individuals can be triggered by various environmental factors, which we will discuss in subsequent part of the video. Let's move forward. Now we know, like in any kind of autoinflammatory disease, we have a long friend, long important friend, the T cell. Now T cell is a very important arm of the immunity. Okay, but what happens when you have some kind of immune dysregulation and privilege breakdown? What do we mean by privilege breakdown? Hair follicle is an immune privilege site. We have discussed that in the previous lectures. We mean by that is that immune cells fail to recognize what is happening in the hair follicle, and that is entirely normal. But if this privilege, this barrier gets broken down and the immune cells start recognizing hair follicle proteins, you have destruction of the hair follicle leading to alopecia. Okay. You can also have hair autoantigens. Now, what are these? These are those molecules which are normal, they are normally present in the body, but because of loss of immunoprivilege, they have been exposed to immune cells. And now the immune cells are making a lot of antibodies, or they have started to make a good inflammatory immune attack on the hair follicle, because now they have started to recognize these antigens as something which has come outside the body. They have failed to recognize that these are our antigens, these are our molecules, our proteins, and that is why it's immune dysregulated damage to hair follicles. Okay. And with these responses, you have an autoreactive T cell. Now, autoreactive T cells is going to destroy those hair follicles in alopecia areata. It has failed to recognize that what it is destroying is just the part of body. Let's move forward. Now, in pathogenesis, we know it's an autoimmune T cell mediated disease, predominantly Th1 type, with an interferon gamma response. Now, interferon gamma we have also seen in vitiligo. Search and find the video on pathogenesis of vitiligo. It's there on the channel, and we have discussed in depth about interferon gamma in that video. Now, this pathway is somewhat regulated by the JAK-STAT receptors, and that is why JAK-STAT inhibitors work in alopecia areata. You have drugs like baricitinib or tofacitinib or aprocitenib in alopecia areata, because the pathway is mediated by JAK-STAT, but the main actor in the pathway is interferon gamma. Now, this interferon gamma will stimulate CD8 positive or NKG2D positive or group 2D positive cells. These are subset of natural killer cells, NK cells. And because of that, you have infiltration of these immune cells around the hair follicles. Okay. There is also increased MHC expression. Now remember, in hair follicles, MHC expression is downregulated. It is suppressed. And in this suppression of MHC leads to that immune privilege. When MHC is overexpressed, the immune privilege breaks down. So there's breakdown of hair follicle immune privilege. Okay. And when that shield is broken down, a lot more inflammatory cells are going to come near the hair follicle. They will attach themselves to MHC expression and they will destroy the hair follicles. Clear? There's also increased interleukin 15. Interleukin 15 stimulates cells, CD8 positive, NKG2, G2D positive cytotoxic T cells, and these cells will produce interferon gamma, the main actor of pathogenesis. They will also produce more interleukin 15, and that creates a positive feedback loop. And there is continued autoimmune damage. Okay, so there's activation of immune cells which will release interferon gamma, and this interferon gamma is going to lead to hair follicle damage. Just remember this. We'll discuss each and every pathway in detail. Now, because of this, because of damage of hair follicle, remember while studying the hair follicle cycle, we discussed that anagen is the growth phase and catagen is when everything goes back. So if the hair follicle is destroyed, it needs to start the cycle again. And how it will start? It will go from anagen to catagen. But normally, let's say if a hair has to go into catagen, it will go after, let's say, 2 years. But if there's an immune damage, it will have to start from catagen at that point itself. So the cycle, the duration of anagen phase is reduced. So the hair follicle transfers itself from anagen to catagen prematurely. So this transition is a premature transition to catagen phase. Okay. Now, hair regrowth is possible as long as the stem cells are not damaged. In prolonged or a long duration disease, the stem cells can get damaged, and because of that, in long-standing alopecias, you will have difficulty in growing hair. So, as long as the stem cells are preserved, the hair can regrow. Let's move forward. Now, I will be discussing pathogenesis under these headings: autoimmunity, immune privilege breakdown, the genetics, environmental factors, and associated syndromes. So let's discuss them one by one. First is autoimmune hypothesis. Now, why is it that we remember alopecia areata as an autoimmune disorder? It's an immune-mediated damage to hair follicles. Why? Because alopecia areata is associated with other autoimmune disorders like hypothyroidism or Hashimoto's thyroiditis or vitiligo, okay, or Graves' disease. There are also genetic associations with other autoimmune disorders. That means the genes implicated in alopecia areata are also implicated in other disorders. In vitro, anti-hair follicle antibodies have been found in the serum of patients. So antibodies against proteins like trichohyalin or tyrosine-related peptide 2, these all antibodies have been found in the serum. So there is some immune-mediated recognition of antigens happening. There's perifollicular bulb T cell infiltrate. So if this is the hair shaft, and let me just draw it again. Yeah, so let's say this is the hair shaft. Around the bulb, there will be infiltrate of T cells. And this was one of the first evidences that alopecia areata is an immune mediated disorder, autoimmune mediated disorder. So T cells are around the bulb. Okay. Now, multiple animal models, especially murine models, we use mice. So, in multiple animal models, if you deplete CD4 positive or CD8 positive cells, the hair growth happens. So, something is happening with the immune cells. Hair regrowth also happens when skin is transplanted into an immunodeficient mice. So, in immunodeficient mice, you're not able to elicit a good immune response, and hair follicle grows because there's no immunity. T cells from patients with alopecia areata can induce alopecia in an autologous scalp. So, if you transplant T cells from a patient to an autologous scalp, the hair is gone, the hair falls. Additionally, there's response to immunosuppressive treatments. Treatments like corticosteroids, methotrexates, PUVA, all of these immunosuppressive agents or immunomodulatory agents lead to a response in alopecia areata and hair growth. So, because of all these points, we know that an autoimmune hypothesis is one of the strongest hypotheses against in alopecia areata. No, you have autoreactive CD4 and CD8 positive T cells, which are found around the bulb and the intrafollicular area, and that leads to inflammation. Now, remember, everything is happening in the anagen follicles. So, the anagen follicles are the target for the immune cells. The growing hair follicle is the target. There are other cells like CD4 positive, macrophages, Langerhans cells, and also NK cell markers. That means these are those cells which show markers of the natural killer cell lineage, NK cell lineage. Okay. Now, in cicatricial alopecia, remember alopecia areata is non-cicatricial, it's non-scarring. In cicatricial alopecia, where there is scarring, the infiltrate is found around the isthmus. And we know from our previous lectures, isthmus is the area where you have hair bulge. Okay, you have hair bulge, and hair bulge has stem cells. So if the hair bulge is damaged, the stem cells are damaged, the hair does not grow, and that leads to scarring. Okay, so as long as the stem cells are okay, the hair will regrow. That is why in cicatricial alopecia, the hair doesn't regrow because the stem cells are damaged. Why? Because the inflammation is happening at the level of isthmus where you have hair bulge area. Okay, but in a non-cicatricial alopecia like alopecia areata, the infiltrates around the bulb area. So the stem cells may be preserved and hair regrowth happens. So again, you have the dendritic cells. Now this blue amorphous cell is a dendritic cell. It has its dendrites, long processes, and that will engulf or get activated in the presence of MHC and antigens. So MHC and antigens will activate dendritic cells. Upon activation, it will stimulate normal T cells in the body and will convert them to autoreactive T cells. And these autoreactive T cells are going to damage the hair follicle. But what leads to the activation of dendritic cells? We'll discuss them in the next section. Now, antigen presentation. We know antigen presentation is done by dendritic cells. Dendritic cells, okay? Dendritic cells presents exposed antigens through the skin draining lymph nodes to NK cells and cytotoxic T cells. So what will happen is you will have an antigen. Dendritic cell will recognize that antigen. It will go to the nearest lymph node, the draining lymph node, and there it will activate NK cell and cytotoxic T cells. Cytotoxic T cells, and these activated T cells will go towards the hair follicle where they will recognize MHC, they will recognize ICAM, they will recognize ECAM. These are all adhesion molecules, and after recognition, they will attach themselves around the hair follicle and destroy. That is the basic pathology happening. Okay. Now, co-stimulatory molecules like CTLA4, which is a skin homing molecule. Skin homing means these molecules induces the migration of immune cells towards the skin. And these are also implicated in disorders like vitiligo or psoriasis, where the immune cells migrate to the skin. Now, CATLA4 and B7 are co-stimulatory molecules. That means both molecules will stimulate the immune cells together so that they become autoreactive T cells. Clear? T regulatory cells, which are usually normally present in the immunity, and their population is increased during immune damage. Why? Because we need regulators also. In the body, if any process starts, the process to stop the initial process also starts. So T regulatory are like brakes to the immune system. But in alopecia areata murine models, that means mice models, the T regulatory population is also suppressed. So the brake is not powerful and the immune system is going uncontrolled and leading to damage of hair follicles. So after stimulation by catalophorin B7 co-stimulatory molecules, the T cells are now autoreactive. Clear? Let's move forward. Now, plasmacyte or dendritic cells. These are same as dendritic cells, but they have been activated now. Okay, so dendritic cells have activated. They produce interferon alpha, which is the initial cytokine, which will eventually stimulate the cells to produce interferon gamma. These dendritic cells will also activate cytotoxic T cells because that's what they do. And upon activation, they will secrete interferon gamma and CXCL10. These are all stimulatory molecules to inflammation. We know that NK cell also secretes interferon gamma. So now we remember that interferon gamma concentration is increasing in the system in alopecia areata. Now, these plasmacytodendritic cells are found in the hair bulb cells suprabulbar region in patients. Additionally, interleukin 17 lineage, which we see in psoriasis, have been also implicated. But it's not a major pathway as of now. Further research might change some things, but as of now, interleukin 17 has been implicated, but it's not the major pathway. The major pathway remains the Th1 mediated and interferon gamma mediated inflammatory cascade. Clear? Let's move forward. This diagram is just in short what is actually happening. During anagen phase, when the immune privilege of the hair follicle should be highest, the immune privilege, if by any reason breaks down, it leads to exposure of the antigens. The exposure increases during the catagen phase. Why? Because in catagen, all the cells are dying. So they're releasing proteins in the system. And if there is no immune privilege, the immunity will recognize those antigens and they will be damaged. Clear? Now, these antigens will be captured by the dendritic cells or the antigen presenting cells. And these antigen presenting cells will activate the Th cells in the lymph node and will lead to formation of cytotoxic T cells. There's also stimulation of B cells, which will form the autoantibodies, which we find in the system of alopecia areata patients. Whether these autoantibodies have any major role to play, we don't know as of now. Majorly, it's a cell-mediated immune response in alopecia areata. Clear? Let's move forward. Now, let's discuss the another important aspect in alopecia areata where we will discuss the breakdown of immune privilege. Okay. When the immune privilege breaks down, there's invasion by natural killer cells and CD8 positive cells. This is known as initiation of alopecia areata. Now the alopecia areata started. Pro-inflammatory cytokines, interferon gamma is secreted. And what is the source of these cytokines? NK cells and CD8 positive cells. These cytokines will downstream increase interleukin 15 and interleukin 15 R alpha. And the source for these interleukins are follicular keratinocytes. So keratinocytes around the hair follicle will start secreting interleukin 15 and 15 receptor alpha. These inflammatory cytokines, pro-inflammatory cytokines, will promote and sustain CD8 positive T cell autoreactivity. So what happens is that after the NK cells and CD8 positive cells come to the hair follicle, they will secrete interferon gamma. Interferon gamma will sustain and also promote. That means it will increase the T cell reactivity and it will keep the T cell reactivity active. So it is an onset, it's an initiator also, and it's a persister also. Other cells and pathways also contribute to hair follicle damage. We might discuss them in the later part of the video. Now, this interferon gamma or the pro-inflammatory cytokines further break down hair follicle immune privilege. How further? Because interferon gamma is responsible for calling all the immune cells near the hair follicle. Okay. Now, interferon gamma When it calls the immune cells will cause damage to hair follicles. When the damage to hair follicles happen, the cells get damaged, they will release their proteins, and these proteins will further increase the inflammatory damage, further increase the immune damage, and the cycle keeps on continuing and keeps on increasing gradually in alopecia areata. And that is why you have in disease in which you have continued hair loss, and the patch spreads. It spreads centrifugally. Why? Because all the surrounding hair follicles are continue to get damaged. Okay. Remember, in alopecia areata, the hair follicles which are damaged, but if the stem cells are still present, it might grow back. In fact, the hair follicle tries to grow back in a patch of alopecia, but it is continuously being damaged by immune cells. That is why when you use immunosuppressive therapy in alopecia areata, the damage by the immune cells is suppressed and the hair is allowed to grow. That is why drugs like minoxidil alone don't work in hair growth. If you give alopecia areata patient only minoxidil, nothing is going to happen because the hair follicle will definitely get damaged by immune cells. You need to stop the immune damage in order for hair follicles to grow. Okay. Now with this damage, the hair enters the catagen phase. Why? Because the hair needs to grow again. Something has gone wrong. The hair cycle is not normal this time. I'm getting damaged by immune cells. I need to start the cycle again. I'll go into catagen. During catagen, there's more influx of inflammatory cells. Why? Because the cells are continuously being damaged in catagen phase. First, they're getting damaged by the immune cells. Second, they're getting damaged by the catagen phase. And more damage, more proteins, more antigens, more inflammation, more immunity, more immune-mediated damage. Okay? Now, there's an influx of inflammatory cells and antigen-presenting cells during the catagen phase, and this leads to further breakdown of immune privilege. Clear? So even a slight breakdown can initiate a cascading effect in which further whole immune privilege gets broken down. Now, with the understanding of autoimmune hypothesis and the understanding of breakdown of immune privilege, let us summarize what is happening in alopecia areata. Okay? So you have the hair follicle, and the layer around the hair follicle is nothing but immune privilege. The shield around the hair follicle that protects the hair from immunity as the hair goes from anagen to catagen to telogen. Okay. Now let's say because of any trigger, there is migration of inflammatory cells, majorly CD8 positive T cells initially. Now these CD8 positive T cells are the cells which have been activated by antigen presenting cells in the lymph nodes. APCs like dendritic cells. Clear? There is immune privilege breakdown, either as an initial event or as a continued event because of inflammatory damage. So either it has started as immune privilege breakdown or any trigger has started the immune privilege breakdown. Okay. Now after immune privilege breakdown, you have increased expression of MHC. With MHC, you have expression of ICAM, which are adhesion molecules. Okay, so because of the expression of MHC and ICAM, more and more inflammatory cells are going to come around the hair follicle. So you have the hair follicle, and now you have cells in purple and in red. The purple one are the T cells, while the red one are natural killer cells. Now the natural killer cells and the T cells together will damage the hair follicle. Now MHC expression can be increased first and then immunoprivilege breakdown, or immunoprivilege breakdown can lead to increased MHC. This kind of can happen interchangeably, but majorly it's the breakdown of breakdown of immune privilege that leads to the damage to hair follicles. Clear? Now, after the expression of ICAM and MHC and other inflammatory cells and the migration of natural killer cells, we have the third player, which is interferon gamma. And this interferon gamma is secreted by natural killer cells and T cells. So with the presence of interferon gamma around it, the inflammatory cascade begins and immune-mediated destruction of hair follicle starts. So this interferon gamma inflammation happens. Now, after happening, this leads to hair follicle damage because of immune cells. So a lot of immune cells will damage the hair follicle. Immune cells will damage to hair follicles. Okay. Now, further damage to hair follicle will release antigens in the system. And these antigens will get recognized by antigen-presenting cells, T lymphocytes, and this leads to formation of autoantigens or antigen-mediated recognition of hair. Now remember, hair is a privileged site. The immunity doesn't know that hair exists, but if the immune privilege gets broken down, The immunity suddenly realizes that you have other proteins in the system. These are our proteins, but the immunity thinks that these are the proteins. And because of that, it starts the inflammatory damage against it. Okay. So both of this inflammation through interferon gamma and the antigen release leads to premature catagen phase. So the hair has to enter because of a lot of damage has happened. Hair enters from anagen to catagen. So now we can see that the hair follicle is small. It has entered catagen phase. Okay, and the inflammatory damage has increased. The inflammatory cells have increased. The interferon gamma is also increased, and if the damage keeps on continuing, it leads to hair follicle shedding. The hair follicle eventually gets sheds out, and you have alopecia areata. Okay. Now, genetic susceptibility, that means genetically predetermined to form to have to be a patient of alopecia. If there's any genetic problems, any prerequisites, so it can act on all of these pathways. It can make your immunoprivilege weaker so that it is easier to break. It can also increase the expression of MHC1. It can cause more follicular damage because the follicles are genetically susceptible to get damaged easily. You can produce more interferon gamma genetically. You can have more autoantigen release genetically. So all the factors are under control of genetic susceptibility. That means a patient who is genetically susceptible just requires few triggers to go into alopecia. Okay. And all this finally leads to alopecia areata or pattern hair loss or patchy hair loss, I should say. Let's move forward. Now, coming to the third aspect, which is genetics. We know that 10 to 20% of the patient have positive family history, especially when the onset is less than 30 years. And this has been stated as one of the poor prognostic markers in alopecia areata. If parents suffer from alopecia areata, children have about 6% risk. It's 40 to 50% in monozygotic twins, and in monozygotic twins, you have similar onset and patterns of alopecia. The same ratio is seen in about 0 to 10% of dizygotic twins. So in monozygotic twins, you have a similar onset, similar patterns of alopecia. You have 40 to 50% risk of developing alopecia if your monozygotic twin has alopecia. MHC class 2 class alleles like HLA-DQ-B10301, HLA-DR-B11104, and in fact DR-B7 has also been implicated, but majorly these two HLA alleles have been implicated in alopecia areata. And these HLA alleles are responsible for controlling activation and proliferation of regulatory T cells. So normally regulatory T cells will take care that during hair cycle the immune system doesn't get activated. But if these regulatory T cells are not working properly, you can have breakdown of immune privilege. Clear? Let's move forward. Now, environment factors. Remember, you have to mention environmental factors, but also mention that there are diverse triggers, different kind of triggers, and all have conflicting evidences. No firm conclusion can be drawn. In some articles, some trigger is said to activate alopecia areata, and in other article, no correlation has been made. Okay. So emotional stress, traumatic event, dust mite allergy as taken as a marker of early onset alopecia, allergic rhinitis, recurrent disease, vitamin D deficiency, zinc, iron, folate deficiency, all have been found in patients, but no good correlation have been made with environmental factors and alopecia areata. In fact, the severity of alopecia areata has not found to depend on any environmental factors. Okay. Viruses like Epstein-Barr, Hep B, Hep C, SARS-CoV, they all induce DAMPs and they can lead to immune damage, but a good positive correlation has not been implicated. Let's move forward. No. Alopecia areata have some associated diseases which you need to look out while examining a patient of alopecia areata. About 16% of alopecia areata patients have other coexisting autoimmune conditions. 7 to 66% have nail changes, so we have to look at the nail. It's a poor prognostic marker again. 40% can have atopy, 8 to 28% can have autoimmune thyroiditis, 2.5 to 4.1% vitiligo, zero point 0.6 diabetes mellitus type 1, which is the insulin resistant diabetes mellitus, and 0.6% lupus erythematosus. So all of these are the associated immune conditions. There are a lot more, but these are some that I have mentioned. Now we know that hair cycles are altered, so in 1 or 2 minutes we'll just discuss. In anagen, the immune privilege is present. Anagen phase needs to have immune privilege because it is growing. So growing cells can initiate an immune response in the body. So in order to protect itself, the anagen has immune privilege. When immune system is exposed to antigens during catagen, because during catagen the cells are dying, all the proteins are being released. So immune system can get exposed a lot during catagen because of increased apoptosis and organization of cellular architecture. A term is mentioned here, dysfunctional autophagy. Now, what is autophagy? Autophagy is through which cells of the body remove the apoptotic cells of the body. That means whenever a cell completes its life cycle, it is removed by the immune cells, and that has happened every time the hair follicle enters catagen. If there's some dysregulation in this process and these cells are not removed properly, this can activate the immune system and thus start alopecia areata. Okay, so that theory is known as dysfunctional autophagy. Okay, so low level antigen exposure happens during hair antigens to antigen presenting cells. It is quite normal. It happens when the hair goes from anagen to catagen to telogen, but all of this exposure is limited by the controlling processes of the body. When these controlling processes don't work, you have breakdown in immune privilege and alopecia areata starts. So you can have a dystrophic anagen. That means during anagen phase, the hair follicle gets dystrophy, releasing antigens in the system, and this antigen release can activate antigen presenting cells, which can further activate NK cells and CD8 positive cells, and this can lead to immune damage. Clear? You also have truncated cycling. Remember we talked about shortening of anagen phase, so the hair follicle doesn't get time to grow properly. And you can have prolonged telogen. The hair stays in telogen phase. These cells which are dividing in telogen and readying themselves for the next anagen phase are not able to do so properly. Why? Because they're constantly being damaged by immune cells. Clear? Let's move forward. So, a new term that has been described or I came across is autoimmune alopecia areata. And we know that why we call it as autoimmune alopecia areata, because other autoimmune diseases have been associated. There is perifollicular lymphocytic infiltrate. There's increased antigen presenting cells, macrophages, Langerhans cells around the follicles in an active disease. There is upregulation of MHC1 and 2. There is ICAM and ELAM, which are adhesion molecules. Interleukin 2 and interferon gamma are inflammatory activating cytokines, which are also increased. Increase IgG follicular antigens, increase complement deposition, and response to immunomodulatory therapy. All of these points towards an autoimmune etiology. But it has been described that there are two types of alopecia areata. One is autoimmune mediated, in which you need to give immunosuppressive agents to suppress the disease activity. That responds well to methotrexate, cyclosporin, steroids. Another, you can have a non-autoimmune mediated alopecia areata, in which you just have to restore the immune privilege, and this will respond better to drugs which are non-steroidal or non-immunosuppressive, like JAK inhibitors, like PUVA, like contact allergens. Okay, so these kind of drugs will help in those kind of patients who might have a hint of non-autoimmune alopecia areata. So we need to understand if the disease is not responding to immunosuppressive drugs, you might need to add a contact allergen or JAK inhibitors. Okay, you add JAK inhibitors not to suppress immune system but to modulate immune system. Okay, and if we are able to identify somehow that if the patient that I'm treating has autoimmune mediated damage or more of a non-autoimmune mediated damage, we can tailor the therapy to that person, and that is a basis of personalized medicine. Okay, so let's move forward. Now, further insights which are required in alopecia areata, we don't have any autoantigen. We have many candidates, but we don't have antigens which we can block and suppress alopecia areata. We have not been able to find a good autoantigen. We need to work more on role of regulatory immune cells, cells like T regulatory cells, or cells which produce TGF beta 1 and beta 2. These are all suppressive, immunosuppressive cytokines. So we need to work more, increase the levels so that alopecia areata can be treated. We know that there are multiple pathways that can lead to alopecia areata. We have delta T cells, CD8 positive T cells, NK cells, antigen presenting cells, macrophages, LH. Everything is secreting interferon gamma, interferon alpha. There's some role of TNF alpha, interleukin 17. So all of these pathways are acting in alopecia areata. We need to have blockers for each and every pathway like we have in psoriasis. We can also block cytokines the same way that we do in psoriasis, which is a multifactorial or a multi-pathway disease. We need to have some biomarkers so that we can easily diagnose, early diagnose, we can prognosticate whether the patient is responding or not. We need to have good biomarkers. Okay, for example, CXCL10 have been used as a biomarker, but we need to have better biomarkers for alopecia. We need to work on how to restore immune privilege breakdown. Remember, alopecia areata, one of the initiating factor is breakdown of immune system. If we can somehow repair that damage and we restore the immune privilege of the hair follicle, we can prevent relapses or we can shorten the treatment duration in alopecia areata. There's a lot of talk of role of hair and gut microbiome in pathogenesis cytokine profile. If you're more interested, you can go through many articles and how they help in restoring the immune privilege of the hair follicle and thereby help in alopecia areata. So while making this video, I've come across or I've read a lot of articles. Some of them I'm mentioning here. I'll mention them in the description also, so you can copy paste and find the articles and read it if you're more interested. Now, again, reminding you about two levels of membership. Now we have the the lowermost level is Ruby level, and we'll have specific videos. I will not repeat what you will get. All the previous videos I've been repeating what special features the Ruby members get. You will have longer, better videos, and after this year has started, we have another level now, and this level is the Sapphire level. In Sapphire level, you will have same day or earlier access to videos. Okay, and slowly, I will shift more towards Sapphire membership. I'll have earlier videos, longer videos for the Sapphire members, but I'm giving time of roughly about 3 months from April onwards. We'll first launch the videos on Sapphire membership, and gradually after a month or so, it will be available to Ruby members. Of course, the videos for members only will not be available for the public. We have a truncated, shorter video to quickly explain what is the topic, and we'll go in depth so that you can have a better and intuitive understanding. Also, there are some specific videos which I will gradually make in the future, and they will be accessible only to Sapphire members. Okay, you do have a priority reply to comments. I do reply. I do get late, but the members have a priority for their reply to their comments. Okay, let's move forward. Remember, all the suggestions that I asked from my members, the members get their priority, and among the members, the Sapphire members will get priority over the Ruby members. So I would request you all to consider joining Sapphire membership if you think that these video lectures are good and it gives me more motivation to create good video lectures and a good database in which current and future residents and even post residents can see and refurbish their knowledge. Let's move forward. So with that in mind, we will stop this not quick, I think it has crossed 55 minutes, a quick discussion on pathomechanism of alopecia areata. I hope it is now clear and you will not answer the question as what is the pathology of alopecia areata. It's not autoimmune mediated damage only. The breakdown of immune privilege has to be mentioned. It's a very important aspect of alopecia areata. You need to understand when to stop using immunosuppressive agents, and you will understand that only when you know what is happening in alopecia areata. If there are so many frequent relapses, there's no point in using JAK stats. It's better to give a proper immunosuppressive agents so that you can limit the damage and then work on hair growth. And after this video, I hope you understand that how only minoxidil is not going to work. Minoxidil is not a treatment for alopecia areata. It can stimulate hair growth, but what is the point of stimulating hair growth when you have ongoing immune damage to hair follicles? Okay, it is like creating a wall and destroying it in the night, then creating again in the morning and destroying it. There's no point. Stop the immune damage and the hair follicle will start to grow. If it's not growing properly, you may use minoxidil. That is the concept behind alopecia areata. So just don't follow blindly the guidelines or whatever you have been told or taught or something. Do your own research and find out the best possible way that you can help your patients whenever they come to discuss alopecia areata with you. And if you are if anyone who is suffering from alopecia areata and somehow come across this video, go and discuss with your dermatologist about all the options. Ask questions, learn to understand your disease better. You will understand the treatment better. Okay. With that being said, adios, bye bye, and we'll meet again next week with some other topic. Bye.